Hi everyone, this is the second presentation on otitis media. If you haven't listened to the first one, kindly pause right now, listen to that so that you'll be able to understand where we will be heading to better than just starting from this. So this is the second presentation on otitis media. There's another one already published, 18 minutes video before this one. So get that one, listen to it, then start this one. Okay, here's the scenario. The mother picks the phone and tells her doctor that, Doc, my daughter is having trouble with her hair. She's just pulling the hair and holding the hair. And the doctor will say, I have to see the baby. And when the mom dropped, the father asks, why must he see her? And the mom will look at the husband, honey, I just have to take the child to him at the clinic. And the man will ask again, why dad? Nothing, no, nothing much. And the mom turns and looks at the daughter and says, Mary, let's go to the clinic right away. So let's go to the topic, the clinical features right away. It might be non-specific, in which case there's fever, there's restlessness, poor feeding, or in other case, they have anorexia, vomiting, diarrhea, irritable, apathy. When they are older, could complain they have headache or poor sleeping pattern. All these are non-specific because they could be suffering from anything that present like these or some of these symptoms. So this is non-specific. So it is not only in acute otitis media that you are going to have all these features that I've just listed here. Okay. However, we have specific clinical features of otitis media. Otalgia, ear pain, or ear tugging, or ear rubbing. Okay, in that case, you are already being narrowed down to ear trouble, but you don't know where it is yet, and you don't know how bad it is. Okay, at least it's not tummy, it's not the hand, it's not the legs, it is ear. Conductive hearing loss and otorrhea if there's perforation of the tympanic membrane. So when you see otorrhea, then you have to rule out perforated tympanic membrane. It may be associated with conjunctivitis in a syndrome called otitis conjunctivitis. There's possibility of bullous meningitis. That is a painful bully on the tympanic membrane. The doctors will say that by the time they use the equipment to look into the air. With otoscopy for the diagnosis, the tympanic membrane could be seen on physical examination with otoscope to be bulging tympanic membrane. There may be nerves paused behind the tympanic membrane. Tympanic membrane will be aporemic, and there's possibility of obturation of handle of the long process of malleus. In other words, it's not going to be feasible. So these are features that the doctor will pick when he or she uses the otoscope to look at the tympanic membrane of the affected child here. To be bulging, there could be pus, could be aporemic, and long process of malleus will not be visible. What are the treatments here? The treatment will depend on so many factors. First is, if this child is greater than 2 years old and the child is having mild symptoms and the immune system of this child is strong, that is immune competent, all physical examination done, no anatomical anomalies, then you observe only. But you need to explain the situation to the caregiver about the risk and benefits of observing this child on. However, because this is not a conventional system, many centers will just give analgesics and antibiotics. But if this child is between 6 months to 2 years with unilateral acute otitis media and mild symptoms, observation is not bad, but failure rate is going to be high. In my case, I would rather treat with antibiotics and analgesic here, but strictly follow the protocol at your center or jurisdiction. If you want to treat pain, so many doctors will give acetaminophen alone. Some will give ibuprofen, while some will combine both. The pain treatment only if it is less than 48 hours and the temperature is not high, is below 39 degrees Celsius, and this child has received all vaccinations up to date. Okay? Some will give the decongestants and antihistamine. Well, that is very, very controversial. Those who even administer the decongestants and antihistamine, or one of them, they are not claiming that they are curing acute otitis media. Rather, they claim that it relieves the nasal congestion in those children who have upper respiratory tract infection. In other words, you can't base your treatment on the target to eradicate acute otitis media in this child by giving decongestants or antihistamine or both. You are not treating that. You are only treating nasal congestion. That is what some authorities have written down in their books. You have a choice to make, but if you want to deal with acute otitis media, decongestants and antihistamine are not doing the job. Yes, antibiotics. This is the core of the treatment. The first line is amoxicillin, and it is comfortable to prescribe amoxicillin if, one, there is no beta-lactam antibiotics in the last 1 month. Remember, I said the other time, in the case of strep pneumo in a child who has been exposed to antibiotics recently, we might have a difficult situation. Now, you want to prescribe amoxicillin. The question is, hello, any amoxicillin in the last 1 month? Or any other drug in that group? 2, no conjunctivitis that is purulent. You've done the physical examination, no conjunctivitis. But if there's conjunctivitis that is purulent, then no amoxicillin. No resistance to amoxicillin in the past acute otitis media. How will you know that? This child, the history is revealing that he or she had acute otitis media 2 years ago. You treated for days and you were not able to get out of it, or the other doctor treated for days, couldn't get out of it. Then it needed to switch over to another antibiotic like clavulane, that is amoxicillin and clavulanate, or we even go to cephalosporin, which means amoxicillin failed in the past. So if that has happened in the past, no amoxicillin today. If number 1 to 3 are met, which means no beta-lactam antibiotics in the last 1 month, no purulent conjunctivitis, no resistance to amoxicillin in the past, then you can use amoxicillin today. And use amoxicillin at a very high dosage, 80 milligrams per kilogram per day in 2 divided doses. Some go as far as 90 milligrams per kilogram per day in 2 divided doses. If amoxicillin recently and there is conjunctivitis right now, then add clavulanate. So that could be given as clavulane, as combination of amoxicillin and clavulanate. You can also decide to go for ceftriaxone or ceftriaxone, and if this child is allergic to penicillin, drop all of them, use macrolides like azithromycin, clarithromycin, Septra. But when you need to use Septra, some other company, Bactrim, that is a combination of trimethoprim and sulfamethoxazole, be sure that this child is not allergic to sulfonamide before using either. If the first line medication is not working well, then we might be dealing with Immobilus influenzae or Moraxella catarrhalis. So we go for the second line agents like clavulane and cephalosporins. Finally, use antibiotics regardless of age if the symptoms are already greater than 48 hours. There is very high temperature, there's purulent discharge, and on otoscopy, you're able to pick classical features. So don't bother about observation here. Go straight to antibiotics and adjust. Okay. In conclusion, for now, be ready for the last presentation on acute otitis media. And what would that be all about? Complications. So watch out. Thank you watching my presentations. Please subscribe to my channel and you'll be able to get these presentations as soon as they're published. Thank you.